Good afternoon. Thank you for joining us for the Ask the Experts webinar series. Before we get started, I'm going to share some housekeeping items for today's webinar. Everyone on the call will remain muted for the duration of the webinar. And at the end, we will open the floor for live Q&A. We encourage you to ask questions, and you can submit your questions at any time using the chat box feature in the Zoom platform. If you would like to ask your question live, simply click on the Raise Your Hand button and we will unmute you during the Q&A portion. For today's webinar on breast cancer risk assessment, we are joined by Dr. Sobel and Brook White. We also have your physician liaison, Travis Roseborough, on the phone. If you have any needs regarding patient education, referral forms, or other materials, Travis can stop by for a visit at your practice. Dr. Amy Sobel is a board-certified radiologist practicing in the Charlotte community for over 20 years, along with her husband, who is an OBGYN with Atrium Health. Dr. Sobel is the section chief of the Division of Breast Imaging at Charlotte Radiology, where she is subspecialized in breast imaging. Dr. Sobel completed her residency and fellowship at the University of Virginia Health Sciences Center in Charlottesville, Virginia, and she is currently completing a master's degree in public health with a concentration in public policy at UNC Chapel School of Global Public Health. In her spare time, she enjoys spending time with her husband and sons. Brook White has been a genetic counselor specializing in oncology in the Charlotte metro area for nearly 20 years. She currently serves as the coordinator for Charlotte Radiology's newly launched Personal Risk Assessment Program. I will now pass it over to Dr. Sobel to begin the presentation.
Thanks so much, Alexa, and thanks so much for taking the time out of your busy schedules to be here to learn about risk assessment. We want to let our community of providers know that we are implementing a risk assessment program which will directly impact both our screening and diagnostic mammography population. This program will encompass approximately 150,000 women in our community, primarily between the ages of 40 and 75, with the occasional outlier. And because of the scope of this program, not only are we trying to familiarize as many providers as possible with the concept, we want to provide you with the education tools you will need to help your patients navigate risk. The goal of our risk assessment program is really to identify those patients at an elevated lifetime risk of developing breast cancer, or those that may have a genetic predisposition who would otherwise go undetected. Charlotte Radiology has a unique opportunity to capture the relevant information in this patient population at the time of our mammography intake. We knew that implementing a risk assessment program in our population would be a Herculean task, and we wanted to do it thoughtfully, and we wanted to do it correctly. And to that end, we were lucky enough to have Brook join us to educate us and guide us in the process. So I'm going to turn this over to Brook for a while to go into more detail. Brook, take it away.
Thank you, Dr. Sobel. Can everyone hear me? We good? All right, thank you. All right, so today I wanted to just take a few moments and talk a little bit about breast cancer risk assessment. I'm going to go over an overview of what breast cancer risk assessment is, as well as some rationale for performing it. And then in addition, we'll go over some details for Charlotte Radiology's personal risk assessment protocol, as well as some support and resources for our patients and providers. So I first have a very lengthy definition of breast cancer risk assessment for you. Breast cancer risk assessment involves the use of a statistical model to estimate a woman's risk for developing breast cancer over a defined period of time. There are a number of statistical or mathematical models that are used to assess breast cancer risk. Historically, Gale and Kloss were some of the first used, but now we have several others that have joined them. Examples include things like Tyrer-Cuzick, also known as IBIS, that we're going to talk more about later. Also Boadicea, BRCAPRO, and a fair amount of others as well. It's important to keep in mind that each model is unique. Various risk factors are incorporated into the model and are also weighted differently. And it's also important to think about the fact that family history really is only one component in most risk models. So these risk models go bigger than just family history. Most of the time when people think about breast cancer risk, the first thing that comes to mind is, well, does the woman have a family history? Many families, but a lot of women with breast cancer don't have a family history of disease. And so with the breadth and the robustness of these models, we actually can detect some women at increased risk for breast cancer with no significant family history. In addition to the statistical model, another important component of breast cancer risk assessment is the defined period of time that you're looking at risk. So risk assessment may be short term, and oftentimes that's defined as the risk over the next 5 or 10 years. It may also be long term or over the course of a woman's lifetime. Currently in the US, most of the time you'll see either a 5-year risk or a lifetime risk estimate, where in the literature, oftentimes European countries will use the 10-year risk. So if you're reading, you may see that as well. So in addition to the statistical model for breast cancer risk assessment, we also have hereditary risk. And hereditary risk isn't necessarily based on a mathematical or statistical model, although it is based on some data. It really is clinical criteria that we look for in a family to determine if they may have the presence of a genetic predisposition to cancer. These are things that you commonly probably know or think about when you think about breast cancer risk, things like close relatives with early onset breast cancer, multiple relatives with breast cancer, or even breast or ovarian cancer in the family. As we go along, it's really important to consider that statistical modeling and hereditary risk, although sometimes can be correlated, oftentimes are two separate entities. So a woman could have an increased risk for breast cancer based on a statistical model and maybe not have that hereditary risk in her family. So after that background, we want to talk a little bit about why it might be important to assess for breast cancer risk. The main goal of the program is to find women who have an increased risk for breast cancer who may benefit from supplemental services, things like enhanced screening, consultations, management help. And in addition to that, risk assessment can actually provide women with information regarding their risk based more on statistics than their perception. Most women have some kind of perception of what their breast cancer risk is, but a lot of literature suggests that sometimes women can misperceive that risk. And risk perception is also a very strong motivator for women. So giving them some data will help them to better engage in preventative and screening behaviors. In addition to these reasons, there are several clinical guidelines out there that support breast cancer risk, and I've just listed a few here. The American College of Obstetrics and Gynecology cites the potential benefits of risk assessment. The American Society of Breast Surgeons, as well as the American College of Radiology, recommend it. And then one that we really tend to have our pulse on the most is the National Comprehensive Cancer Network, or NCCN. You'll hear me referring to these guidelines throughout the talk, and they include risk assessment within the algorithm for breast cancer screening. So we now arrive at Charlotte Radiology and where we come into play. Looking at all of this rationale and all of the guidelines, we came to realize that through our mammography services, we really have a unique opportunity to provide risk assessment to many women in the Charlotte metro area, particularly through our mammography services. As Dr. Sobel mentioned, we thought that this was probably going to be some kind of Herculean task. Turns out that it is. And so in 2019, we did a pilot study to evaluate some of the clinical and operational effects of risk assessment data. We performed risk assessment on about 1,800 women, and we learned things from how our mathematical model was performing in the population to patient feedback, provider feedback, the downstream effects of risk assessment, and a whole host of other things. And these data were then used to inform a more broad scale implementation of the program. So the way that it works is that mammography patients are offered the opportunity to complete a questionnaire at their appointment. The questionnaire is voluntary and it is also free of charge to them. Their responses, if they fill it out, are coupled with a density score from a mammogram, and a lifetime risk of breast cancer based on the Tyrer-Cuzick version 8 model is calculated. Tyrer-Cuzick, this model defines lifetime risk for breast cancer as the risk of breast cancer between the present day and when that particular woman turns 85. As you may guess, the Tyrer-Cuzick model does account for many risk factors. Some of the things that are most heavily weighted within the model are the woman's age, her BMI, her breast density, a few things about hormonal history, as well as prior biopsies, family history, and genetic testing. Once we calculate the woman's lifetime risk, it is then categorized, and these categories are really derived from NCCN criteria, where a woman with less than a 15% risk for breast cancer is considered to be average risk. Those with a 15 to 20% lifetime risk are intermediate, and those over 20% are considered to be increased. In addition, we do look for some of those risk factors to identify hereditary breast cancer or those clinical criteria, things like the early onset breast cancer in the family. I apologize, this is a complex slide. It is derived from NCCN again, and it is the clinical implications of risk assessment. So if we start at the top with a woman with a lifetime risk for breast cancer, the recommendation is annual screening mammography. In addition, some women with increased breast density may personally choose some supplemental surveillance options like abbreviated breast MRI and screening breast ultrasound. Dr. Sobel is going to go into this in a few minutes in detail, so I'm going to let her address some of those. The same kind of thing with intermediate lifetime risk. So these women should continue their screening mammography, and in addition may also consider some additional surveillance options based on a personal or kind of a case-by-case basis. And then finally, really the category that we're most concerned about and most interested in are those women who have over a 20% lifetime risk. Again, mammograms should be considered or should be continued, and breast MRIs can be considered as well in this population. Also, risk reduction strategies, genetic counseling, and referral to a breast specialist may also benefit these women. And finally, those who are at a hereditary or genetic risk may benefit from genetic counseling and the potential for genetic testing as well. So in addition to all this information, we realize it is a lot, and one of our goals is to provide some general education to our patients. Really, the whole idea behind this is that if we can give them a general understanding of what breast cancer risk assessment is and their particular category of results, we really hope that that will facilitate a more targeted and effective conversation between them and their provider, so that the provider doesn't have to spend as much time explaining the basics of risk assessment, and it can be a more personalized conversation. We give women the opportunity to reach out to us through phone numbers. They can learn more information through our website. And then I did bring an example of one type of information that we do give to patients as well. And I apologize, unless you have like Superman eyes, you probably can't read this. It is a draft, I do have to tell you that, and the language is subject to change. But this is an attachment to the woman's mammography report, and we kind of call it our Understanding Your Results. Basically, what it says is, what is breast cancer risk assessment and why did I have it? What does it mean to have this particular category of results? And what are some next steps or considerations based on this information? It also lists some resources for the women as well. Obviously, in addition to supporting our patients, we very much want to support our providers. We realize that any new program does have the potential of disrupting or maybe increasing workflow, and we certainly want this to be as seamless as possible. We do have a phone number for providers to call if they need additional information. We also have a very provider-specific email, so if a provider has a question, sometimes it's a little easier to drop us a line than to try to play phone tag and that kind of thing. So we're happy to field those as well. They will get information on the mammography report. And then we spent a lot of time with some physicians in our community. We were fortunate enough to be able to pick their brains, and they really helped us in terms of thinking about workflow with breast cancer risk assessment. One of the main things we learned is that not all providers are the same. They all have very different preferences, which isn't a surprise, and their workflows are very different. Share this as maybe you think about incorporating this into practice. At the top, there is the risk results, and they are given to the provider as well as the patient. And then some providers told us, you know what, I really would like to have this risk discussion myself, or maybe a member of my staff with the patient. And any subsequent surveillance or management or downflow from that, I would like to take on. Other providers said, you know, I'd really rather refer this. And so there is the opportunity to refer for consultation within the Charlotte Metro community. Usually how this works is that the patient would go to genetic counseling. And genetic counseling would have a very in-depth discussion with them about their risk assessment. They would also relook at the family history to see if there's any indications for hereditary cancer and offer genetic testing if that is the case. And then once that discussion is finished, they could consider going to a high-risk breast clinic where they can help with some of the imaging, the risk reduction options, the surveillance, management, et cetera, and then work in conjunction with that initial provider to help with risk. So I'm going to turn it over to Dr. Sobel now, who's going to talk a little bit more about the supplemental screenings, and we'll go from there.
Thank you so much, Brooke. A couple of things I just want to reemphasize. This program is being offered to the patients as a service in conjunction with mammography. There is no additional charge for patient risk assessment. Multiple institutions, both academic and community-based, have been doing this for years. And truthfully, we have been talking about doing it since 2006. This program was incredibly well received, but we do anticipate that there will be patients for their own reasons who decline to participate. So you as our providers will be notified if that, and the additional caveat is, as with any model, the output is only as good as the input. So therefore, the patient's risk is based entirely upon what the information they provide to us. Let's look at supplemental screening options. As always, mammography is still the only modality proven to decrease disease-specific mortality for breast cancer. That being said, we know mammography has limitations, right? Especially in women with dense parenchyma. Mammography is about 85% sensitive for all comers, meaning that about 10 to 15% of breast cancers may not be visible on mammograms. And when you tease out the dense breast, that sensitivity actually decreases to anywhere between 48 and 64%, depending on the study you read. As you may very likely recall, that was the reason for the nationwide dense breast information grassroots movement and the subsequent legislation, which was passed here in North Carolina in 2014. But as many of you may remember, with that legislation came no specific detailed recommendations for action or additional coverage, just speak to your provider. But there are, however, supplemental screening options for women with average risk and dense breast parenchyma, and also those with intermediate and high risk categories. And these include screening breast ultrasound, full diagnostic protocol MRI, abbreviated MRI, and the NCCN provides us some basic guidelines within these frames. Just to touch on the basics, the cancer detection rate, or CDR, of tomosynthesis, also known as 3D mammography, is about 5.6 per 1,000 asymptomatic women that we see. And we know from multiple studies that if you add in a screening breast ultrasound in addition to the mammogram, we're going to find an additional 3 to 4 cancers per 1,000. And these are usually small invasive node negative tumors, which are the ones that you want to find. The way that we offer screening breast ultrasound at Charlotte Radiology is that these studies are performed by a dedicated technologist. They usually take about 45 minutes. Any patient can actually self-refer, or a provider can order, as long as that patient has had a negative mammogram within the past 12 months. So a screening breast ultrasound, it's very important, does not replace annual mammography, which is an important message for patients. This is a great example for patients who wish to pursue supplemental screening, but in whom MRIs may be contraindicated or not tolerated. Breast MRI, however, is the most sensitive exam we have for breast cancer detection, reported to be about 98%. And it's based on the exploitation of abnormal vascularity between breast cancers and the normal background breast tissue. Therefore, you have to use IV gadolinium. It's required to evaluate for malignancies. A full diagnostic protocol takes about 15 minutes on the table. These can only be ordered by a provider and usually require insurance pre-approval. They are currently the standard of care in patients who are high risk, either by statistical calculation or have a known hereditary mutation. We're going to loop back to that in a second. New to our armamentarium is abbreviated MRI, which is also known as fast MRI. And it is the most accurately named exam ever, as it's basically it's essentially a shortened version of a full diagnostic protocol, and it decreases the patient's time on the table from about 15 minutes to between 6 and 8 minutes. Multiple studies have demonstrated that we have an analogous cancer detection rate, sensitivity, and specificity in abbreviated MRI to the full diagnostic protocols. But these studies were performed in the average and intermediate risk populations. The data in the high-risk patients is currently evolving. So for those patients at this time, full diagnostic protocol is still recommended. I anticipate this will change probably in the near future, maybe within the next year or so. So as the data is collected, we will readdress this. But right now, the intended populations for abbreviated MRI are those of average risk with dense breast or immediate risk of any density. Currently, there is no CPT code for abbreviated MRI, so it is a $399 out-of-pocket payment. and the study still necessitates a physician referral and IV gadolinium administration. So that wraps up the informational part of the presentation. Brooke and I are, again, very grateful for you to take your time to be with us here during lunch, which is, usually in short supply. We are really here to support you and your patients, so do not hesitate to reach out to us with any questions. I'm going to hand it back over to Alexa, and we're open for any questions.
Great. Thank you so much, Dr. Sobel and Brooke, for this informative presentation. So now we're going to go ahead and go into our live Q&A portion of the webinar. And again, to enter in your questions, you can use the chat box feature in the Zoom platform, or if you would like to ask your question live, simply click on the raise your hand button and we'll go through and unmute you so that way you can speak directly to Dr. Sobel and Brooke. So we'll go ahead and give it a minute or so for people to go ahead and start entering in those questions. Okay, it looks like I do have one question that's coming in. So it says, my patient was found to be at an increased risk for breast cancer, but her out-of-pocket cost for breast MRI is prohibitive. What are her options?
So currently the recommendations are still for the full diagnostic protocol, but we want patients to get the care that they need. And we know that it is better for them to have a supplemental MRI than to have no additional supplemental screening. So in that case, I would reach out to us and we will do what we need to do to make sure patients get the care they need.
Okay, excellent. Thank you, Dr. Sobel. All right, so we do have another question that just came in. It says that they have a 40-year-old patient who has no family history of breast cancer, but she was found to be at an increased risk. Is this an accurate result?
I'll take that one. Yes, it probably is an accurate result. We sure hope so. This certainly can happen. And it goes back to that whole conversation about mathematical and statistical risk versus hereditary risk. So it sounds like the patient was on the younger side with no family history. A lot of times we will see that that patients in their 40s may be at increased risk. And there's a couple of factors besides family history that can really drive that risk into the increased category. Usually it's a correlation and combination and interaction between BMI and breast density that can drive that risk up. And then oftentimes there's something else within her personal history that's modulating that risk. Maybe something about her hormonal history or late parity, or something that's kind of making that risk go up a little bit from that. The other important thing to think about is that age does have a huge factor on statistical models. So when you're looking at lifetime risk, it's a bit counterintuitive, but a woman who has who is younger actually has a lot more years within her lifetime risk than a woman maybe in her 70s or 80s. And so the risk for a younger woman for lifetime is going to be a little higher than if she's 70, just because of the mere years that you're calculating. So we do from time to time see younger women who have an increased risk and no family history because of that age, as well as multiple other factors within the statistical model.
Well said. Thank you, Brooke. All right, so those are all the questions that we have right now. We'll give it another minute or so to see if anyone else has any last minute questions. But thank you, Dr. Sobel. Thank you, Brooke, so much for speaking with us today. And thank you to everyone on the line for joining us. This session was recorded and a copy of this recording will be sent in a follow-up email to you after the webinar. And if you have any questions, here is the contact information on the slide that you are welcome to reach out to them and they will help you answer any sort of patient questions that you may have. All right, yep, I don't see any other questions coming through. So again, thank you so much everyone for joining us today, and I hope you have a great rest of your afternoon.
Thank you.
Thanks again.
Thank you, guys.